Thank you. So I work in East London, helping diagnose patients with blood cancers. I'm here today talking in my role as chair of the UK HMDS network, which is very kindly supported by the British Society of Haematology, the BSH. And just my next slide summarizes that UK HMDS network. So in the UK, there are about 25 hematological malignancy diagnostics services, so HMDS labs, that diagnose patients with blood cancer. So we're here to represent them and their patients. And what we do is bring them together with other key stakeholders, such as the BSH, the British Lymphoma Pathology Group, which is focused on histopathology of lymphomas largely, but also working with NHSE in terms of the Genomic Medicine Service and other genomics commissioners, and a few other organisations. And in particular, we've had some very successful, fruitful collaborations with NECRAS LI over the past few years, and we'll talk a little bit about what we're doing there as well. So this is the problem. So blood cancer, on their own, the individual blood cancers, leukemias, lymphomas that we know are relatively rare, but collectively, they're the fifth most common cancer in the UK. And it is the third biggest cancer killer. So whilst we often congratulate ourselves on how far we've advanced in terms of diagnosis and treatment, it's still a big problem. And one of the reviews of the NICE guidance, the NG47 guidance about how to diagnose and treat patients with cancer, is probably the most important thing we can do in terms of improving the outcomes, making people live longer, curing them, is to actually improve the diagnosis, because you can spend a hell of a lot of money on expensive new drugs, but if you get the diagnosis wrong at the beginning using relatively less money, then that money is wasted, but more importantly, the patient's harmed. So that's still a challenge to us all. Now, in many ways, hematology and hematopathology have pioneered precision medicine for many other disciplines as well. So we're already living in the future. It's just not very evenly distributed, as one of the quotes I often use, saying in many cases, we're at the cutting edge of personalized medicine. So over many years, we incorporated genomics, immunophenotyping, other diagnostic modalities into diagnosing blood cancer. So we really pioneered this. And at the moment, one estimate is about 50% of all the genomics activity in the English Genomic Medicine Service is related to hemato-oncology, SHMDS genomics as well, just showing how we've been leading the way even before that national service was set up. And that super specialization is really good for patients because we can now truly introduce precision and personalized medicine for those patients. But actually, that requires higher and higher standards. And that means we have to train up people. And those trained people are very rare and they retire, unfortunately. So it also brings up challenges. So things are becoming much more advanced, in some ways more simple, but also more complex. And I'll talk about that as well. So why are we so far ahead of other parts of medicine? Well, partly we've got lucky, is that some leukemias are relatively simple in terms of genomics and biology. And the first sort of molecularly defined entity was chronic myeloid leukemia, defined by the Philadelphia chromosome many, many decades ago. And that, of course, is one of the success stories of personalized medicine. There's also something about the background. Many of the patients, particularly children, are affected. So that can make things in some ways easier. But also, we've learned a lot more about how aging affects cancer. And what is true about hematology and clonal hematopoiesis is also true of solid tumors as well. So we've learned a lot about that. And we've learned a lot about subcloned resistance and how relapse happens. We've developed measurable residual disease targets, both by genomics and by immunophenotyping. And we're also experts in inherited cancers and inherited blood conditions. So we've got an inherent understanding of genomics and inherited conditions. Another way I look at it as well is the recent 10-year plan outlined the 3 shifts that we need to think about. Now, in many ways, these aren't novel, but we haven't implemented them at scale. It's about how we move treatment and diagnosis closer to the patient in the community, how we move from analog to digital, which is quite important, how we apply prevention rather than a sickness service to address patients. Now, some of these are more or less relevant to diagnosing blood cancers as well. So one of the first obvious things suggested I talk about is artificial intelligence, this move from subjective, human-based, looking down the microscope, to more sort of digital AI techniques. And that has many applications in hematology and hematopathology more generally. It's impossible for me to comprehensively cover this, but I will sort of just do some introductions. So first of all, digital pathology is introducing the idea of what we look at down the microscope can be turned into an image, and like radiology, we can analyze the image using machine learning AI to possibly overcome the subjective aspect of me looking down the microscope and sometimes find things that I cannot detect because I'm not, essentially my brain isn't big enough. A lot of this has been done in solid tumors, but there's a lot been done in blood cancers as well. So first of all, looking at images of blood cancers, largely lymphoma, and then combining that with genomics. There have been some newer sort of models which probably have some applications in the future, but it's still not yet developed, not yet validated, partly because a lot of these cancers aren't scanned, but also because the complexity of blood cancers is not quite as simple as some of the other more solid approaches. One of the more interesting ones is not just taking the images, but putting things together in terms of flow cytometry, genomics, and other aspects to have an integrative approach. Essentially, it's summarized on the next page by putting together all these different parts of information. We can then use AI to put it together and hopefully come up with some better answers for our patients. But there's a lot of anxiety around AI. There's, first of all, this aspect that what we put in, we're not quite sure how they're analyzing it. People are quite concerned about the ethics of it, and people are quite unsure about whether human supervision versus machine autonomy, how we're going to possibly undermine ourselves in the future. And there's also people worried about their jobs, of course. But the most important thing is that so far there haven't been lots of validated techniques that really truly work, that fulfill the promise of AI. That will come, but it's not yet here. And at the moment, there's probably a belief that it will help prioritize cases for more urgent triage rather than replacing experts. So this is probably what the future looks like. It's still uncertain, but it's going to enhance our expertise in the same way that automation has not replaced the need for human beings, but it's enabled scientists and medics to act at the top of their license to do more complex tasks. The routine stuff can be taken out of the way. The other important aspect of analog to digital and the role of blood cancer diagnostics, the role of genomics. So we've increasingly found a role over the years of genomics defining the entities that we diagnose and treat. And a really good example is that of acute myeloid leukemia, AML, with recurrent genetic abnormalities. Initially, back a couple of WHO classifications ago, there were about a quarter of cases defined by a number of gene fusions and other mutations. And over the years, as classifications and science has advanced, we've incorporated more and more targets to define these entities. And that's also playing an increasingly important role in myelodysplastic neoplasms. So rather than just focusing on blast counts and subjective assessments of dysplasia, we're using molecular techniques to almost replace some of these things. But that doesn't necessarily make things simpler. So an example given by a colleague, John Bertham, about a month ago, talking about AI in diagnostics. The WHO has about 29 different AML subtypes and ICC 52. But actually, when you start adding all of the genomic markers, the other qualifiers, that leads into thousands. So literally, the classifications we have at the moment define hundreds of different blood cancers. When you add that up with all the different ways you can subdivide it, that leads up to thousands. That's what personalized precision medicine is. Personalized almost means unique to that individual patient. So it also isn't that simple. So on the left, we have these different entities defined by the genomics, but we're hoping that white gap would be filled as we see accumulating more mutations, but not that simple, because the genomics is much more like on the right, where it's complex combination of different markers. And actually, as you treat patients, different subclones come through and promote resistance and relapse. So this is a moving target. So this is what precision medicine means, is that we are defining each patient's cancer on genomics and other techniques, but it's almost each cancer is unique to that patient, and each patient cancer evolves. And when you add in the inherited predisposition and pharmacogenomics, it really shows how precision medicine is changing how we think about things. This leads on to one of the other shifts about sickness prevention. Largely people think, well, what relevance does this have for hematopathology? But it's also changing what we think is normal, because as we go out and we use these much more sensitive tests in patients who appear otherwise, or not patients, people who appear otherwise well, we often find they've got the precursors to blood cancers. So we find they've got monoclonal B-cell lymphocytosis, which is a precursor to CLL. We find they've got the precursor to myeloma. And when the same techniques of genomics is applied to people who appear otherwise healthy with normal blood counts, we find they've got clonal hematopoiesis. So trying to go out there and screen for these disorders is not recommended. But when we look for these disorders in with very sensitive techniques, we find them in healthy people as well. So what is normal, what is prevention, is not yet defined as well. So it's not getting simpler, it's getting better, but that doesn't mean it's simpler. And all of these different problems with assays, with experts being unreliable, all add up to making things difficult. And we all need to consider it in the clinical context. And genomics on its own does not supersede the other techniques as well. And one of the problems, as alluded to earlier, is that classifications changed. So back in the 19th century and the early 20th century, depending on which side of the Atlantic you were on, you could get different diagnoses. So it was only in 2001 that the World Health Organization, WHO classification, the Blue Book, brought things together into one classification, which made things simpler. Increasingly over that time, genomics was applied to further define things, lump things together, but also split things. Now, many of us know about the problem then occurred a few years ago with rival classification systems arising, the WHO and the ICC, neither of which is incorrect in itself, and often they're overlapping, but there's no way of suggesting that the WHO, the ICC is better than the other. And so we're left with this really difficult situation a few years ago where we're basically having to use both. Now, the British Society of Hematology, the BLPT, worked together to come up with a kind of fudge to give guidance to people in the UK about how to use these two new classification systems. And it was generally felt there's an acceptance that you have to use both, unfortunately. So it took a few years for the full classification to be published, but the few recommendations we could make are that WHO 5 is better than the WHO 4th revision, but some people might still want to use that because in some clinical trials and other guidelines, the 4th edition are still being used. And a recommendation that where there is a difference, we should also use the ICC. In my lab, we use all three different classifications to integrate the report. So it's not ideal. However, there is light at the end of the tunnel. A recent article in Blood highlighted how the warring families have come together to develop a better system. They recognize this as a problem, and hopefully, possibly this year, but more likely next year, the two different classification systems are going to be unified again into the 6th edition of the WHO. So that should provide us with a little bit more light. So again, coming back to why we're so advanced, a lot of it is about how we access treatments, how we access samples for research and treatments, but also the actionable targets. That's the key thing. We have new drugs, new treatments, new cellular therapies, and we're using the latest techniques to treat people differently. So suddenly these newer genomic markers become quite important, but integrated diagnostics we've pioneered as well. So again, there's this key point that whilst genomics is important, on its own, it cannot provide an answer. And a lot of studies show that you misdiagnose a patient if you do not diagnose them outside an SHMDS setting where all the different modalities are brought together and aligned with hemato-oncology, MDTs, and clinical pathways as well. So integrated reporting is really at the heart of this. A lot of the focus has been on whether all of the different 25 labs are following that integrated approach, and there's quite rightly some attention on that. And we've been working with NEQAS LI on various schemes because, as Sam illustrated quite well before, immunophenotyping on its own, without morphology, without genomics, it's actually very hard to interpret to give a suggested diagnosis because integrated reporting is the way forward. And we're working with NEQAS LI on developing an integrated EQA scheme to really recognize how we do things in reality. I'm much more interested in whether patients are actually accessing an HMDS. So they're sending all the samples as they're supposed to all the right place, because there's been a lot of situations where sometimes local reporting morphology happens, or sometimes the genomics is sent to a different place, and that leads to errors and leads to problems as well. So that's an important focus for us as well. So this is what we think is the current landscape. 25 different HMDSs in the UK. We're all working together to learn from each other. There are challenges because to create the ideal model, you need to spend a lot of money to bring it all together, put it in one place, have a single IT system, and often IT systems don't talk to each other. And co-location is really the best way of doing that. And various economic analysis showing that doing it other ways is less efficient and accurate. People see the world in different ways, whether you're from a histopathology or a scientific or a medical background versus a clinical genetics background. People see the world differently, and that surprisingly leads to lots of miscommunication. And we need to recognise that patients don't turn up at their cancer clinic saying, I think I've got lymphoma. And there's been a lot of concerns about genomic medicine service reconfigurations destabilising this ideal model. So one of the challenges, the new genomic medicine service is quite rightly trying to innovate by introducing whole genome sequencing, WGS, not yet found its place, but it will in the fullness of time. But the greater focus nowadays is focused on increasing numbers of targets earlier. So some tests, such as PMRR, we want in a few hours, but increasingly the tests that we need within 3 days, three working days, including weekends, not only include NPM1 and FLT3 for acute myeloid leukemia, but things such as IDH1 and 2, TP53, and other variants are coming through as well. So increasingly, there's a focus on much more tests using multiplex NGS to develop, giving those results within 72 hours, which you can only really do in your local HMDS, where you need the same staff, the same platforms as doing things which are less urgent for other diseases. So this pressure to decrease the turnaround time target is increasing because some of the new drugs, many of them are sold as the best thing since sliced bread, but many of them are actually proving their virtue now and why we need to treat patients with acute leukemia upfront. Other diseases are less aggressive and need less urgency, but it's the same staff, the same platforms. And the same thing applies to MRD as well. People want more sensitive MRD, but they also want their result yesterday if possible. There's a lot of concern with the model, with the new National Genomic Medicine Service in England, which has got a focus on not just whole genome sequencing, but consolidating the testing into fewer labs with the hope that that will reduce costs. But there's a lot of antagonism to this, and most people in the UK, most HMDS experts are really concerned about this and actually do not think that that national model of consolidation is actually compatible with NG47 and the rapid testing and the need for myeloid NGS being provided within the SHMDS. And again, going back to the 3 shifts in the NHS, this kind of move from the community. SHMDS is a really highly consolidated lab serving their regions aligned with MDTs and pathology networks. But even further consolidation creates a lot of anxiety concern with the model of the genomic medicine service. So that's something we're addressing as well. So how do we overcome these challenges? Well, you have to get together. You have to collaborate. Just a month ago, we had a really good meeting at the Royal College of Pathologists, bringing together the HMDS laboratories, the various stakeholders, the Royal College, NHS England, NECOAS, to talk about what we're learning from each other. We looked at workforce, we looked at those genomics challenges, those genomics concerns. There was a really interesting demonstration of AI. There's a couple of really good collaborations between ourselves and NECOAS ALI about their flow cytometry network that Tim may talk about, and about integrated reporting, integrated EQA. So Sam was talking about the next steps in the LI collaboration. I've already alluded to the fact that we want to work together to develop an EQA scheme for integrated reporting. And the British Lymphoma Pathology Group also run a similar EQA, a slightly different focus, but again, we're working with them really closely. So the HMDS network, and if you're part of the UK in terms of diagnosing blood cancers, I encourage you to join our mailing lists, and we are working together to try and look after our patients and support each other and learn from each other and work on some very specific projects to ensure that our patients have access to the latest high quality diagnostics. So again, just to go back to some of the stuff I said before, blood cancer, we've made big advances, but it's still a big problem and patients are really struggling. And the most important thing we can do for them is making sure we get the diagnosis right, we get it faster, we get it more accurate, and we make sure that it doesn't come back as well. So hematopathology, really at the cutting edge, and an almost invented personalized precision medicine. Other parts of medicine are following us. And working together both with NECOAS LI and other stakeholders to try and create the future. And it depends on which philosopher you choose. I'm less keen on Oprah Winfrey, though I value her greatly. And I think I probably follow Abraham Lincoln's approach in the way that predicting the future, no need for a crystal ball, but we actually have to try and change it ourselves. So that's all I've got to say on that. So thank you.
Thank you ever so much, Tom. That was great. I didn't think Oprah Winfrey would be making an appearance today. Yeah, I think the fact that we could be dealing with over 2,000 subtypes of leukemia is quite a sobering fact. We have got some brilliant questions that have come in. So one from an anonymous attendee. Do you think the current training pathways for haematology trainees adequately prepare them for integrated molecular-driven diagnostic testing we now operate in? Is there a gap that needs to be addressed here?
Yeah, it's a very good question. So, and I will interpret that hematology trainees from a scientific background as well as a medical background, because increasingly the boundaries are blurred, quite rightly. But the same problems occur. So I think we provide really good training in the UK of bringing all of these different disciplines together and making people aware of genomic techniques, about flow cytometry, as well as looking down the microscope. So actually, I think we're really good, but that doesn't mean I'm complacent because a month ago we're presenting almost a workforce crisis, whereby we've become so super specialized in some areas that there are very few people who have developed the skills to do this, that then and fewer centers who've got the ability to train people up, that we've almost painting ourselves into a corner. So there's a real possibility we might sleepwalk into a workforce crisis when our current experts retire if we really don't think about training in a much more active way. So I think we're actually very good at training scientists and medics at doing that integrated approach, but we need to work much harder, particularly as you consolidate techniques into SHMDSs and other laboratories. You solve one problem, but you create new ones because you need to be able to train up people, but also train people who aren't necessarily specialists to recognize them in the first place to then seek our advice. So there are good things and bad things.
Well, in your experience, what is the single biggest communication challenge between clinicians and laboratory scientists in the leukemia diagnostic pathway, and how have you tried to address that in your own SIH-MDS?
Gosh, there's a challenging question. So the most important thing is to put the patient first, and that overcomes all the challenges. So you didn't ask about that, but that's how I overcome every sort of really important challenge is that everyone knows they're trying to do the same thing. So even when people get grumpy with each other or fail to communicate, then that focus on the patient really helps. Now we moved into a different world with the pandemic. We're all meeting online, which is good in some ways, but bad in others. And face-to-face meetings as well as online meetings are really important. Developing relationships with people, but as you get bigger and further away from where the patient's being treated, if you're working in a regional centre, that gets harder and harder. So what you've got to do is reach out and build those relationships and then just provide a really good service and offer yourselves up for advice when an urgent result is needed to be issued, a critical result, or if it's a bit more complicated, and that's where the MDT comes in. So you have to work really hard at maintaining that dialogue, but I don't think there's a simple answer to that one.
So the meeting that you put on down in London was brilliant from our point of view in terms of, having time outside of, the diagnostic pathway to actually develop those relationships and, overcome those problems in a sort of, a neutral environment was fab for us. Okay, so I'm afraid I'm going to butcher this name, but I think from Googling, Eve O'Hagan has asked, hi Tom, have you got any clinical scientists trained specifically in hematology working in your department and or pathology network? And if so, what role do they play in the HODS process/reporting?
Well, yes, you're about to hear from one of them, Tim Farron, but he's not the only one. We have people coming from a variety of backgrounds, hematology sort of training route, others focused on the genomic route. Not everyone comes up by the STP HSST program, but yes, we do. And we know from our surveys that we've got consultant clinical scientists, consultant biomedical scientists working around the country, reporting, authorizing, just the same as their other consultant colleagues. But I don't draw the boundary between consultants or people in training and between medics and scientists. If you've been assessed to do something and you're competent at it, then I think we should blur those boundaries and work together. And that's what we do locally. So the answer is yes, and I encourage that. And that's what we're trying to promote in the HMDS network.
That's brilliant. Thank you, Tom. So I think we're going to have to draw a line under the questions there. But yeah, thank you ever so much.